Thanks very much for inviting me to give this interesting presentation on a case study for vaccine-attributable severe dengue in the Philippines and the impact on the national immunization program. Many of you may know that as the Dengvaxia conundrum, or the outfall from that. So many of you will be aware that dengue is a main global health priority with hundreds of millions of dengue infections annually. Many of them require medical attention and have severe outcomes all the way up to death, although death is relatively rare, luckily. The burden is growing rapidly with the expansion of the vector, and there's 4 serotypes of dengue. Typically, if you are infected with one serotype, that will trigger a pan-serotype short-lived immunity for about 6 months to a year, and a longer-lived or even lifelong serotype-specific immunity. What complicates the whole epidemiology of dengue is what is known as antibody-dependent enhancement of disease, which means that if you had an initial infection with one serotype, that is, well, moderately likely to result into severe disease. The second infection with another serotype that you get is much more likely to result in severe disease. And that's because of the existing, or partial existing antibodies that are cross-reacting. So after decades of development, Dengvaxia, the first ever licensed dengue vaccine, showed efficacy against all serotypes in phase 3 trials that finished in, well, initially provided outputs rather in 2015. So these were huge trials conducted all across Latin America and across Asia, including more than 30,000 participants. And that was sufficient to address the primary outcome, which was clinical dengue, and for all serotypes, clinical dengue was reduced by somewhere between 50 to 70% of all serotypes in the groups that was vaccinated. However, not too long afterwards, in the passive follow-up phase of the trial, in the year 3 after initiation of the trial, there was a potential safety signal that was picked up in young children. And that safety signal was that in 2 to 5-year-old children that were unvaccinated, there was 1 case of hospitalized dengue, whereas in the vaccinees, there were 15 cases in that 3rd year of the trial. With a 2-to-1 randomization, that means that the risk in the vaccinated was 7 times higher than that in the control arm. So although there was a post-hoc analysis that was not initially planned, it was just about statistically significant and raised some concern. The question was, where does it potentially originate from? It could be just age-related, because what we found was there is an age gradient in vaccine efficacy. So the older cohorts that were vaccinated had shown a better efficacy. Or is there something that is potentially a proxy for age, which in this case of antibody-dependent enhancements could be the proportion of dengue-naive vaccinees that you have in your intervention arm. So the other hypothesis, other than purely age-related, would be that the vaccine acts similar to a natural infection, and therefore in unexposed individuals would simulate an asymptomatic primary infection and therefore bring forwards, upon exposure, a potentially more severe secondary infection. So, however, the only thing that was observed was a potential safety signal in the 2 to 5-year-olds, and specifically, there was no observation of a safety signal in the 9+-year-olds. And on top of this, modeling has shown that, or at least suggested, that even in the dengue-naive vaccinees, the lifetime net impact would be potentially positive, despite potentially bringing forward the risk. So there was a bit of uncertainty. Nevertheless, the vaccine was licensed relatively quickly following the trials in about 20 countries for use in 9 to 45-year-olds. However, it was only really used in the Philippines and in the Brazil, at least on a larger scale. And that has to do with the recommendations that the WHO has issued for the use of the vaccine, because that was restricted to only high burden settings, meaning that the vaccinees should on average have a 70% chance of having had dengue before, because of that potential safety about. And that is inherently difficult to measure, and therefore only Philippines and Brazil actually use the vaccine. So then for many of the people in the field, there was a sudden change announced by Sanofi in November 2017, because Sanofi announced that they had done some initial studies, and these initial studies were able to, well, back infer the serostatus of the vaccinees, so particularly whether they had dengue before or not, and thereby better get a handle on whether indeed the potential risk is age-related or related to the serostatus of the vaccinee, and therefore would not necessarily go away with increasing age of vaccination. And so they changed the label to recommend the vaccine only in those who are seropositive, so have had dengue before, because they showed that there is a differential impact in those two groups, dengue infection. However, by that time, about 800 people in the Philippines, about 300 people in Brazil had been vaccinated already without knowing their serostatus at time of vaccination. And there was no opportunity to go back to see who would have been likely in the part of the group that are very likely to see a huge benefit of vaccination and who would potentially see their risk being brought forward by vaccination. So subsequently, we went and estimated the likely impact of the vaccination campaign in that cohort in parts of the Philippines. And we found that from extrapolation from the findings of the trials adapted to the Philippine cohort that was vaccinated, we would expect about a 70% decrease in dengue hospitalizations overall in that cohort. And for every one case that the vaccine would have caused in a 5 years time horizon, in those who were dengue naive at time of vaccination, about 18 hospitalizations would have been averted in that part of the population who had dengue before. So a quite one-sided balance of benefits and risks. In those cases and hospitalized cases that would occur during the 5 years after vaccination, we estimated that those cases would mostly, so just over 50%, be attributable to breakthrough infection in those who would overall benefit, so breakthrough infection in those who were seropositive at time of vaccination, owing to the not perfect vaccine efficacy. 25% roughly would be cases in those who were seronegative, so dengue naive at time of vaccination, but would have occurred anyway. And 25% of all the cases that would occur during that 5 year time horizon would be vaccine attributable by bringing the risk forward. However, the reaction in the Philippines was, well, nowhere near as nuanced. It caused, so the publication of Sanofi's label change caused a real social media frenzy with a lot of finger pointing, and, well, rightfully, parents were scared whether they had vaccinated their children with something that could potentially mean harm, and there was no way of telling whether, well, they had or whether they actually did something good for their kids. So it was a statistical problem, but then we all know that we don't really think very statistical when it comes to risk. So in the wake of this, very soon after Sanofi's announcement, the whole program of Dengvaxia was suspended in the Philippines, and Dengvaxia was permanently banned. Even criminal charges were brought to the trialist, Department of Health officers, and well, interestingly, in Brazil, the story was very different. The whole announcement largely went under the radar in Brazil, and only when we talk about the Dengvaxia controversy, we only talk about Philippines, although in Brazil there would have been potential for seeing the same thing, but we didn't. The additional and arguably bigger damage was done to the national immunization program. So in the wake of the Sanofi announcement, vaccine confidence plummeted in the Philippines. And while in 2015, about 82% of the population said that vaccines are generally safe, that feeling dropped to 21% in 2018. And correspondingly, vaccination rates in the national immunization program and the childhood immunization program particularly dropped. And for example, measles vaccination coverage, which took many years to get to a relatively high level of 88% in 2014, dropped to, well, just over 50% in 2019, and led to widespread transmission of measles and a lot of additional disease. So the rates are about 10 to 20-fold higher than they used to be before the Dengvaxia controversy.
Stefan, this is Allison.
Yeah.
2-minute warning, first of all, and second of all, a request that you get closer to the mic because we're having a little audio kind of fade every once in a while.
Okay, I'll go
Thanks.
a bit quicker tonight. So about 10 to 20-fold increase in measles incidence, which partially overwhelmed the healthcare system in the Philippines. So a massive blow to the immunization program. Also felt in other aspects. Polio is another example where polio was largely under control. Now it's one of the concerns to the global eradication programs, which, as you're aware, is one of the most expensive programs that we have in public health. So my lessons learned from that for COVID would be, well, be prepared. When we start vaccinating, this story isn't over. So we will see intense public scrutiny, and we have seen intense public scrutiny for everything related to Dengvaxia, or sorry, for everything related to COVID in the last couple of months. There will also be personal agendas, which can go either way. Vaccinating against COVID will see us vaccinating age groups who are not typically vaccinated, who don't receive a lot of vaccines routinely. And also, there will be temporal associations with unexplained deaths, which will present a challenge. So we will need to have open access to data for the vaccines and for the decision-making process, because we want to avoid that there are conflicts of interest which can be turned into a social media frenzy, as we observed with dengue. It is very important to know the background rates to assess safety in real time, to be able to respond in real time with confidence. So if we vaccinate a whole cohort of 55-year-olds, well, there will be some heart attacks that are temporally associated with the vaccine. If we don't know the background rate, it will be problematic to confidently say that the vaccine is safe. We also need to address the other side, and that's arguably even more difficult. We need to monitor impact in real time. And we potentially, well, we need to set up systems that allow us to monitor in real time, because there will be the question, is the benefit worth the risk, if there is any? And so we could be potentially creative with the likely, well, suboptimal number of doses that we have initially, and potentially control the vaccination program in a way that allows us to estimate in real time, which I think will be a crucial part of success. So thanks for your attention.
Stefan, thanks very much. I think it's really important we all pay attention both to what our broader vaccine program confidence means for individual vaccines, but also this interesting sort of reverse effect or spillover effect of one individual vaccine on a full program. Thank you.